Hi, everyone. So thanks so much to people joining, and to those who will watch later on YouTube as well. Uh, as I always say, um, during these presentations, at any point, if you have any questions, more than welcome to stop me. You can ask questions via the chat, or you can just unmute your mic and just ask. I can hear you quite well, so it's not a problem. So we're going to get into today's ECG. I hope you had a chance to see it on the group. So it was quite an interesting one, and there's quite a bit to go through on it. So I'm going to try and get through it and show you how you would try and approach such an ECG, because there's a few things that need to be seen on it. So here we just have a 26-year-old man with severe weakness and lightheadedness. So as I always say, if this was a patient you hadn't seen, you were told, listen, this is a patient that we've got with severe weakness and lightheadedness, you'd probably want his vitals first. You probably want to check his heart rate. And when you checked his heart rate, you would notice there would be something abnormal. And most likely what you would notice is the bradycardia that he's got. So it's quite a significant bradycardia, but we'll get to that just now. And that bradycardia would probably prompt you to say, okay, listen, let's have a look at an ECG. And then you do your ECG, and this is what you find. And when you see an ECG like this, it might be a bit overwhelming at first, because there seems to be quite a bit going on. Now, the first thing always is, if you're unsure, break it down into little pieces. And once you've broken it down into little pieces, then ask for help if you can't get an answer. And if you can figure out the answer, then go ahead. But hopefully we'll try and figure it out. So the first thing, as I always say, we always look at the axis for the patient. So we look at lead 1 and lead AVF. And what we notice is that lead 1 is biphasic and lead AVF is positive. So actually what we've got is a borderline right-sided normal axis. So it's on the border of being a right-sided axis, but technically speaking, it's still within the normal range, So the more important thing is actually going to be the rhythm strip. So let's have a look at the rhythm strip and let's see what we've got. So what we can see here is that we've got P waves. All right, we are seeing P waves. The one thing that we notice is that the P waves not all the same. Some are a bit shallow, some are a bit more humped, some are, not so they're not exactly the same. So there's something not 100% with the P wave morphology. But the one thing that we do notice is that our PR interval is a bit enlarged. Now, for those of you who have been following the lectures, you know that we go through P wave, PR interval. We look at our QRS complexes. Does a QRS follow every P, and are they regular as well? Okay. So the one thing we notice is that we have a long PR interval. So it's about 1, 2, 3, 4, 5. So it's just a bit elongated as compared to normal. All right. If we look at our QRS complexes themselves, they're relatively narrow, right? This is a T wave that we're seeing over here. So we're talking about the QRS complexes here. They are narrow. Does a QRS follow every P? Yes, it does. But are they regular? And the answer is no, they're not regular. That's quite obvious, So what we're seeing is that if you notice, we've got 1, 2, 3 normal beats, and then we get this an extra beat that comes out again. And then we've got 1, 2, 3, and then we've got an extra beat that comes out again, So actually, technically, I don't want to get into the technicalities of this, but in actual fact, this is the abnormal beat, the one that you're actually seeing here, not this one here. But that's a bit technical. I don't want to stress you out about it, but what you've got is that you've got a regular, irregular beat. So if you're feeling the pulse, you'd feel pulse, 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 pulse. And that's how it would continue on. So you'd have regular, irregular beats. Okay. And the rate would be determined by your what you call it, your QRS complexes that are the furthest from one another. So these are quite far. And if you look at them, it's about 1, 2, 3, 4, 5, 6, 7 nearly. So, if you take 300 divided by 7, you're getting quite down there. You're getting into the 50s. So your patient is quite bradycardic, and your patient is experiencing lightheadedness. So chances are your patient's also got a bit of a low BP and hypotensive and things like that. So let's have a look and see. So anybody have any idea what could cause bradycardia? So there's quite a few things that can cause bradycardia. One of the most common ones, of course, is ischemia. So if you have an ischemic episode, it can cause bradycardia. If you have electrolyte imbalances, they can cause bradycardia as well. If you have hypoxia, it can cause bradycardia. If you have direct cardiac trauma, it can cause bradycardia. So it's nice to know all of these causes so that you know more or less what's going on. But anyway, if we look at this, a 26-year-old man, so he's quite young. So we'll probably have to look for a cause such as ischemia or electrolyte imbalances, things like that. Those are the things that we'd have to look at, unless there was a history of trauma or something along those lines. Now, let's go through each of our zones so that we can figure out what's going on. If we look through zone, the inferior zones, in other words, zone leads 2, 3, and AVF, we do see what looks like a little bit of an ST elevation, but not much. And if we were to go on that, then we would expect ST elevations through some of the limb leads, and possibly even on the chest leads and things like that. So I'm so sorry. Somebody's just asking for the Zoom link, so I just want to give it to them. If you can just give me 1 second. Let me just get that for them. So sorry. It will just take me 1 second. So I think one of our colleagues is just asking for that. I think that one or two people have. Sorry, I'll be with you guys in a second. Okay. So, sorry. So getting back to that, so we'd expect to see some ST elevations or possibly something along those lines, well, coming into these, we don't really see that, but we'll get to it now. If we look at the high lateral leads, we look at leads 1 and AVL, sorry, we don't see any ST elevations. And if we look at lead AVR, also, we don't really see any ST elevations per se. There's a thing that we call slurring going on over here, but that's something else completely. All right. Now, if we come to the chest leads, if we look at V1 and V2, we can see they both got Q waves. So Q waves are quite indicative of ischemia sometimes. And we can see that stretches on to lead V3, and you can see there's even maybe a bit of ST elevation. So there is a possibility of an ischemia. When we get to lead V4, V5, and V6, what we notice are these very tall T waves that are coming up over here, all right? And the one thing that I want you to notice is that they're quite pointed. Now, would anybody be willing to take a guess as to what tall pointed T waves might indicate? Because it's an important diagnosis for people to know whether you're working in emergencies, ICU, anesthesia, or medicine. This is an ECG pattern, a tall T wave, peak T wave that's quite sharp. In other words, a T wave that looks like it would be painful to sit on. You can answer in the chat if you have an idea. And if not, I'll just give you a few seconds and then I'll tell you the answer. So we'll just give people just a chance just to think about it. Okay. And it's fine if you don't know, don't worry. That's why you're here. So, I'll explain it to you. So when you have these very, oh, there we go. Let's see. Ah, very good. Very, very good. That's excellent. So it is hyperkalemia. So Wadia, you've been following my lectures for a long time, and you definitely got that 100% right. That I'm very proud of because it's one of the things I've been teaching over the years. So very tall, pointed T waves that look like they would be difficult or very painful to sit on are quite indicative of hyperkalemia. And we're going to talk about that a little bit more. So as soon as we see this in our patient, of course, there are signs of ischemia, but this patient also has signs of hyperkalemia. And hyperkalemia can also mimic ischemia. So it's more important to have a look at the patient's potassium first, especially considering it's a 26-year-old man. It's more likely that he's got an electrolyte abnormality than having an ischemia, although both are possible. So if this patient was with you, you'd, for instance, take let's say a blood gas that could quickly show you your electrolytes, and you would, of course, take your cardiac enzymes that would also possibly show you your, if there was any ischemia. So we're just going to move on from this a little bit, and we're just going to have a look at the answer. Now, it's a sinus bradycardia. The reason why they say that is because we have a QRS following every P. The rate is about 45, so we did say about 50. What we were seeing there were premature atrial complexes, but I don't want you to stress about this too much. This is something completely different. And we have peaked waves, T waves suggestive of hyperkalemia. All right. So as we said, we have a regular, irregular rhythm. It could be a second degree AV block. But with AV blocks, which we'll get to a bit later on, you normally have a missed QRS complex, which we don't have in this case. And the premature atrial complexes are not something I would like you to worry about right now, but they are one of the things that are associated with hyperkalemia, right? So hyperkalemia, as you said, the T waves can be distinguished from other causes of large T waves by a narrow base, symmetric shape, and sharp peaked apex. Like I say, they look very, very painful to sit on, okay? As compared to others which tend to have a broad base, they're more rounded at the apex. So for example, let's say hyperacute T waves seen in ischemia tend to be much rounder. So I just want to go back and just, for example, just show you the difference. So this would be quite typical of let's say, of a hyperkalemia. But, if you were to have a hyperacute T wave, you'd probably see something more like this. So it tends to be less symmetrical and much more rounded in shape. So once you see something like that, it's unlikely to be hyperkalemia. Okay. So that's something to always keep in mind whenever you say it, whenever you see it. Hyperkalemia is well known for causing peak T waves, dysrhythmias, unusual bradycardias, AV blocks, fascicular blocks, bundle branch blocks as well. And like I say, in some instances, it can mimic ischemia as well in certain cases. All right. Although in this case, the ischemia may also be due to bradycardia. So we can't exclude that, but the main thing is hyperkalemia. So this is the adult bradycardia algorithm. Now, this is all available online. You don't have to stress about knowing this right now. But if you, let me just hide this away, sorry. So if you were to get a patient and they were to have a bradycardia, the first thing that you would have a look at the heart rate. So if the heart rate is less than 50, it's considered a bradycardia, which we do have. You identify and treat the underlying cause. So in our case, we've identified that the patient is hyperkalemic. So we would treat the hyperkalemia. We wouldn't worry about anything else over here. But for the sake of completion, we'll just go through this just so that you guys know more or less how you would approach a patient, for example, who's bradycardic, but you can't identify the cause. So you would give them oxygen, cardiac monitors, IV access, 12-lead ECG, basically what we would do. And the signs of a dangerous bradycardia are exactly the same as the danger signs for a tachycardia. You have hypotension, And hypotension, of course, leads to an acute altered mental state because there's less blood reaching the brain. You develop signs of shock because there's less blood reaching the peripheries. There's ischemic chest discomfort because there's less blood reaching the heart itself during diastole. And then there's signs of acute heart failure because the heart is unable to contract with any sort of conviction because it's not receiving as much blood. So if your patient doesn't have any of these signs, you can monitor and observe them. It is true. There's a lot of patients who have bradycardias that are not necessarily pathological, so you don't have to necessarily rush to treat them. But if you have a patient who is bradycardic and you haven't identified a cause and they have danger signs, then the first thing that you would do is use atropine. And atropine is normally given as a single amp, so a 0.5 milligram bolus. And it's important to make sure that you just give that bolus quickly and you repeat it every 3 to 5 minutes to a maximum of about 6 amps. And most patients will have recovered within that time. If your atropine is ineffective, you can consider transcutaneous pacing, which I'll discuss just now, dopamine or adrenaline infusions. Now, dopamine infusions are not generally found in emergency departments, but if you have the opportunity to have dopamine in your emergency department, by all means use it. It's a much gentler drug and a much more easier to control drug. But we generally have adrenaline that's more readily available. So the way that you would set up this infusion is you would put 1 amp in 200 mils of crystalloid and you'd run that at about 10 mils per hour. All right. Now, the thing is, atropine works very well for narrow QRS bradycardias. And once you've got wide QRS bradycardias, it doesn't work at all, to be dead honest. But, we'll talk about that in a second as well. And you can also consider transvenous pacing as well. So these are just some of the signs of hyperkalemia on ECG. Now, especially if you're working in an acute setting, this is something that you really need to know because this is the type of thing that you can pick up from your 3-lead ECG prior to your 12-lead ECG being done, where you can see the peak T waves as it starts to go up. As it starts to get more and more, as your potassium starts to get higher up, then you start seeing these widened QRS complexes. You start seeing signs of ST segment elevation, arrhythmias. You lose your P wave sometimes completely. And once you go above 8 milliequals per liter, you start seeing what they call a sine wave pattern. So if you were to see this, for example, once your patient is in a severe, hyperkalemia, you basically start seeing this. So this is what it looks like, a sine wave pattern. And if you've done trigonometry at school, that should look quite familiar because we all learned the sine wave in trigonometry, so that's why they call it the sine wave sine wave, sign, as it's got over there. So this is how potassium progresses as it's going on. And as you can see, eventually you can get ventricular fibrillation, asystole, axis deviations, bundle branch blocks, and fascicular blocks as well. Now, that patient that we had in the answer, their potassium was actually 8.3. So they had probably just started going into this part of it. And that's why we could see some ST segment elevations and ectopic beats and escape rhythms. So what I will tell you is that once your patient has a wide QRS complex with hyperkalemia, the first thing that you're going to do is give them calcium gluconate. It's 10 mils infused over a very short period of time, maybe about 5 to 10 minutes. And then the next thing is to try and bring down your potassium. So each and every hospital generally follows the same basic principles when it comes to reducing potassium. And the first is, of course, to use insulin. So you would normally give a patient about 10 units of insulin, and we would combine that with dextrose, maybe 20 mils or 50% dextrose. And in fact, in patients with very high potassiums, you can mix these all together in 200 mils of a crystalloid solution and give it in over about 5 to 10 minutes. and then you repeat your potassium to see what's going on. If your patient is not as bad, maybe let's say in the earlier parts, you can, of course, exclude the calcium gluconate. But in my experience, I prefer to just give the calcium, because whatever's triggering off the hyperkalemia generally won't be reversed by you giving, treatment for hyperkalemia. You need to reverse the underlying cause. So if there's renal failure, for example, just giving insulin and all of these is not going to reverse renal failure. So giving calcium reduces the excitability of the cardiac tissue, and that makes it less likely for your patient to go into VFib and asystole and things like that. So that's why we give the calcium gluconate. And then albuterol nebulization, extremely effective. You put your patient on continuous nebs, it really does help. And it's also something worth remembering that if your patient has a normal potassium, and if they need nebs for whatever other reason, remember that nebs drop your potassium, so it's something that you need to keep an eye on. Lasix is also a good a drug to give. It does drop potassium quite quickly, but it takes a bit longer than the others, of course, And of course, these can be repeated, to try and bring your potassium down. And should it be a refractory hyperkalemia, then dialysis is the way to go, whether it be peritoneal or hemodialysis is dependent on your intensive care specialist. They will then decide how you would proceed from there. So I hope everybody understands that. I mean, it's not necessarily a lecture on hyperkalemia, but just so that you understand that part. So these are the drugs for bradycardia that you will generally have in the ED. So you start with atropine, 1 amp bolus, and it works very well for narrow QRS bradycardias because it stimulates the vagus nerve, and then the vagus nerve stimulates the sinoatrial node, stimulates the AV node, and then you tend to get back to a normal heart rate or a slightly tachycardic. And then depending on your patient's response, you can give an amp every 3 to 5 minutes. And then if that fails, you give 1 amp of adrenaline in 200 mils of crystalloid at 10 mils per hour. So that 1 amp is going to run over quite some time. I mean, that's going to run over 20 hours. I'll be honest, if your patient has a wide QRS bradycardia, you'd be better off starting this instead of trying to give the atropine. But there's no harm in giving the atropine. It's just that it's unlikely to work. And as we said, if you have a wide QRS brady, let's say due to hyperkalemia, you'd want to give calcium gluconate as well. Okay. So these are 2 videos that are extremely good on transcutaneous pacing and transvenous pacing, which are things that people don't necessarily know how to do. So transcutaneous pacing is basically where you place the pads on the patient's chest, and then you start to pace them from there. And transvenous pacing is similar to putting in a CVP, but you put the CVP with an electrode in it so that it stimulates the contraction of the heart. Now, what I'm going to do is I'm going to put both of these on the group. So I would suggest that you do go and watch them because they're done with demonstrations. They've got the physical machines. They show you how to do it. And it's really quite interesting and much longer than I can, afford to on our, basic Zoom calls and things like that. So it's really worth watching, and I would suggest that you do watch it. And having watched them already, even I learned a thing or two, just as a refresher. So it's really worth watching, and I'll put it up on the group as well. But alternatively, if you want to, you can try and copy it from there. And I'll put it in the description of the video as well. So if you watch it later on YouTube, you can just go down into the description. It will be there. This is just a joke to finish off. I try to find jokes relevant to what we're talking about. But at this point, if anybody has any questions or anything that you'd like to know, or anything that didn't seem clear, or anything that you just want explained a bit better, now's the time to ask. Like I say, you can ask via audio, or you can just put it up on the chat and I'll try and answer it as well. And of course, if you're happy and if the explanation was fine, that's good as well. You can let me know, and then we know if we'll end the discussion. So I'll give you guys a few seconds. You can just decide what would be best. I don't think there's anything that I forgot to mention. I'm hoping to discuss hypokalemia with you guys one of the days, and just different electrolyte imbalances and how it affects the ECG. But hyperkalemia is one of the easiest things to pick up on an ECG, and it can really save your patient's life. And you can start treating hyperkalemia before you've even got blood results, and that just based on the ECG. And if you're confident in what you're seeing, nobody will hold you liable for that. But of course, in majority of the departments, you do have blood gas machines. They can give you electrolytes in a minute or two. And in those cases, it's always better just to wait for an electrolyte reading before you just decide to barrel ahead with treatment. But if you're really sure and you want to go ahead, most people would accept it if you can demonstrate your knowledge of it. So yeah. Seems everybody's okay and everybody understood what was going on. So if it's okay with you guys, then we can end it here. And on Wednesday, I'm hoping to show you guys hopefully Oh, okay, no problem. Just so long as you're happy. Thanks, guys. Okay, just so long as you're happy with all of that, then we'll call it a day. And yeah, on Wednesday, I've got a few presentations prepared, and hopefully, I'll try and show you guys maybe not an ECG, but an emergency department procedure that it's the things that we generally do on a regular basis, but that we need to refresh sometimes. So I hope you'll have a great night, and yeah, I hope you to see you all again on Wednesday. All right. Keep well. Enjoy the rest of your evening. Bye bye.